there, then what would you consider? Anyone? Who said that? What would be considered? Take a mic.
It would be a human type of weakness, sir.
Human type of weakness. So because the uprolling of eyeball has nothing to do with facial innervation. Okay, it's a supracortical. It's a cortical function. So it's because it's a gaze. It's something like a gaze thing. So when facial nerve is involved, there is no reason why you're uprolling your eyeball should, because that's a normal thing. It happens to everyone. It's just that it's visible in a facial weakness. So when you have Bell's phenomena happening, then you know that this is not a human. Okay? Because in bilateral human also, facial weakness, there will be inability to close eyes. So this is an important differentiator between bilateral human and bilateral. And similarly, in element, you are not able to make the lines over the forehead, creases over the forehead. In bilateral human also, because it's a bilateral thing, you will not be able to make the creases. So this sometimes helps you in differentiating bilateral human from bilateral element. Bell's phenomena, if present, it is element. Okay, in this patient, it is beautifully demonstrated. So this is a element facial pulse and not bilateral human.
On motor examination, attitude of the limbs. In upper limb, it was normal. In bilateral lower limb, it was bilateral lower limbs were extended at hip and knee with external rotation with lateral border of the left foot touching the back.
The attitude suggested a
Element
hypotonia.
Hypotonia.
And okay, carry on next.
And the hypotonia at the bilateral wrist and bilateral lower limbs left more than right. In power, in the,
there is a problem with distal power in the wrist, upper limb. Right?
Sir.
Okay. Proximal is okay, upper limb, and in the lower limbs?
In the lower limbs, proximal weakness is more.
Proximal weakness is more than distal weakness. So there is weakness on both proximal, distal, and the lower limb, and proximal is more. So when proximal is more, you are thinking either of a radical or predominantly a radiculopathy, and distal is also weak, so radical or neuropathy. With the caveat that this could also be porphyria. Okay, next.
Further, the deep and reflex.
What does this slide tell you? Any finally? Who's not answer? Anybody? How does this Vikrant? How does this slide help you further in localization?
Sir, areflexia in this patient, sir.
So there is generalized areflexia. None of the reflexes are elicitable. Can you demonstrate the reflex? We have video for that?
Sir.
Go ahead. So how does it help you? Okay, Major Garvita.
More of like multiple nerves involved in polyradicular polyneuropathies.
Okay. So the reflexes are not elicited as against none of the reflexes are elicited. So because the reflex arc is involved, right? You know that the lesion is somewhere in the reflex arc. It is not in the posterior column. So because the reflex arc is involved, a myelopathy will not cause absent reflexes. Okay, only it has to be involved in the reflex arc, the sensory arc and the motor arc. So absent reflex tells you that there is a. Can you go back to that slide again? Previous one tells you that the lesion is in the peripheral nerves, okay, and not in the muscles, and not in the neuromuscular junction. So this cannot be a myasthenia, and this cannot be a polymyositis or a dermatomyositis because your reflexes are absent. So the lesion has to be in the nerves or in the radicals. It is not in the spinal cord as we were thinking earlier that could myelopathy be a consideration. So this is negated spinal cord. It is negated neuromuscular junction as cause of quadripasis, is negated muscle disorder as cause of quadripasis. Okay. Next.
In sensory examination, his vibrations were impaired up to anterior superior iliac spines in bilateral lower limb and distal upper limbs, and proprioception is also impaired in bilateral lower limb and distal upper limbs with Romberg test positive.
As we had seen earlier, sensory ataxia can go all the way to the brain, but because this patient has loss of reflexes, deep tendon reflexes, it cannot be in the spinal cord and higher. It has to be in the sensory arc of the sensory root or the peripheral nerve sensory component. Next. So the Romberg we had discussed earlier, he was what? Cerebral ataxia or sensory ataxia?
Sensitive.
Sensory ataxia. In our patient on closing eyes, can you show it again? On closing eyes, he's okay, fine. On closing eyes, he's losing balance. So that's the positive Romberg. See, he's closed eye and he's losing balance. So, carry on next. Cerebral sign, no medication. Okay, move on. Other systems were normal. Summarize.
31-year-old male has presented with acute onset bilateral facial weakness, element type, and flaccid irreflexive quadriparesis with flexor plantar, with sensory ataxia and absent large fiber sensations and motor paralytic bladder.
One. Has it made any difference to our differentials?
No, sir.
Not much, except that probably at this stage I would not keep myeloradiculopathy as a possibility because we have got absent reflexes, and I would place my bet on polyradicular neuropathy. If the reflexes were present, even if they were present, I would have thought of a myeloradiculopathy. But here the reflexes are completely absent, so I'm thinking of only of a polyradicular neuropathy. And among the etiology, because it is acute, so we have to consider all acute possibilities, and we have to do a extensive workup for a acute polyradicular neuropathy. Carry on.
Investigations done at Jodhpur revealed dengue serology IgM
So
positive.
dengue has come positive. Can dengue lead to a GBS-like picture? Yes, yeah, you're right. So dengue can also lead to a GBS-like picture with sort of various viral etiologies causing polyradicular neuropathy. So dengue is also possible. However, there is a caveat to this. What is odd in this presentation? Anyone? Facial involvement, very good. So this patient has a bifacial involvement that is very, very rare in dengue. At least I have not read or not seen. So dengue can cause a lot of neurological manifestation. Bifacial weaknesses not common. We move on.
The CSF analysis was done at MH
So
Jodhpur.
the CSF was what were you expecting to see in CSF in GBS?
No
Cytological dissociation, which is not there. This is more or less looking like a normal CSF. Okay, right.
The nerve conduction study which was done here, sir.
So what does the nerve conduction show? You can see that the lower limb nerves are not stimulable. Okay, not stimulable. So there is no impulse, there is no recording from there. And in the upper limb, the median and the ulna, you can see that the latency is increased and the conduction velocities are reduced. So that suggests what? Demyelination. So this is a demyelinating etiology that is affecting the upper limbs, and the lower limbs are not stimulable, so we can't make out. But by corollary, because of the upper limb pattern, we can assume that the lower limb is also demyelinating. More. And these are the graphs. You can see that the latency is coming much later. Huge gap. This is increased latency. More. Next. So workup of porphyrin was done to rule out porphyria, and that came out normal. Right. Next. More.
I will request my radiology colleague to discuss the MRI findings.
So MRI brain of this patient was done at Command Hospital, Southern Command. The representative pre and post contrast T1 weighted axial section of the brain at the level of cerebellopontine system shows abnormal enhancement of the intracanalicular part of the right facial nerve, and also abnormal enhancement of the intracanalicular part of the left facial nerve. The rest of the neuroparenchyma, there were no abnormal neuroparenchyma or